Welcome to ICU Primary Prepcast. Hi, my name is Swapnil and I'm joined by Dr. Mike Clifford from Melbourne. Welcome, Mike.
Thanks, Swapnil. Our last one's celebrating Maddie's pregnancy.
That's correct. This is about the uteroplacental blood flow. And so what are the kind of key characteristics and how the gas exchange occurs within this circulation, which is quite unique?
Okay, so this lends itself to a lot of key facts and key numerics that are often asked in the multi-choice component of the examination, because we can ask, which is the following. In a SAQ, you might be expected to describe the differences in circulation on both sides, or you might be able to just talk about the differences in oxygen content of the fetus. We'll sometimes ask about the anatomical and physiological differences in fetal blood flow, but these are all sort of interrelated. The other question we'll sometimes ask in SAQ is, what are the functions of the placenta? In the same way that we would ask, well, what are the functions of the lung, or what are the functions of the liver? It's an incredibly complex organ, and we could talk for hours on the beauty of the immunology that is something that enables you to grow a parasite inside you. It's all about the immunosuppressive effects of growing something that is foreign within the body. It's extraordinary. But we'll just focus on some of the key features of the flow through the system and some of the design features that enable optimization of transplacental gas exchange. So as we've spoken about already with the heart and the lungs, it's important to paint a broader picture before you get into the specifics. So you've got this enormous organ that's bigger and bigger and bigger throughout pregnancy and is maximal at the third trimester. And that's where most of the numbers come from. In the exam, we'll often talk about what are the numbers, and the numbers that you'll find in the textbooks are usually referring to the flow and characteristics of a term placenta. So you're looking at something that's getting about 20% of the cardiac output, and remembering that that's an increase on baseline of 50% to normal. So you're looking at a 7,500 mil cardiac output, and about 20% of that is going through the placenta. So there's at least 600 mils a minute of flow through the uterine artery, and of that, 85% of it is going to the placenta, and 20% of it's going to the tissues around. And if you think about the blood that's going through, it's normally oxygenated and saturated arterial blood. So it's going to have a PO2 of about 100, going to have 98% saturation, and its content is going to be about 16 mils per deciliter. Because remember that the mother has, as we spoke about in the respiratory section, they've got an increase in blood volume and an increase in red cell mass, but there's a disconnect. So there's a subtle anemia. So the content is slightly reduced from normal. And that's going to flood across bathe the membrane that separates the mother from the fetus. And there's some key numbers there. You've got a 12 to 16 metre per squared surface area, 12 to 16 metres squared. And you've got a thickness of about 3.5 micron. And just to help you remember something, 3.5 micron is about the thickness of a platelet. So you're looking at a membrane that's about the thickness of a platelet. The uterine vein, which is draining the placenta, has a PO2 of about 40, which is pretty normal for mixed venous. You've got a saturation of 75%, which is about mixed venous, and you've got an O2 content of about 12 mils of oxygen per deciliter. So there's some numbers. You've got 16 mils of oxygen per deciliter going in, you've got 12 mils of oxygen going out, and you've got a 12 to 16 metre square surface area. So those numbers all help you remember each other, okay? And that's good for your multi-choice examinations. If we have a look at the blood that's coming from the fetus, it's pumping very, very deoxygenated blood back to the placenta and taking away slightly more oxygenated blood. It's nowhere near as oxygenated as the maternal blood in terms of its saturation, but we'll talk about the clues of its content. So the fetus is pumping blood towards the mother that has a PO2 of about 18 millimetres of mercury, which you'll remember is pretty close to the P50. So the saturation of that blood is 45 to 50%. It's very low. And the O2 content is 10 mils per oxygen per deciliter. As it comes back from the placenta, having exchanged oxygen across the membrane with a gradient of about 30, you've got a PO2 of 28, you've got an SO2 of about 70%, and an oxygen content of 16 mils per deciliter. So it's equilibrated from an oxygen carrying point of view with the maternal blood. So it's carrying 16 mils of oxygen back to the baby. And just thinking about the baby's got pumping 300 mils a minute into the placenta. So that's about half what the mother is. And that's about 25 to 50% of the cardiac output of the baby at term. So just ballpark numbers, 30% of the cardiac output, 300 mils a minute. Fetal hemoglobin, which we know is much higher than maternal, it's 180 grams per deciliter, 18 grams per deciliter, or 180 grams per litre, and with a P50 of 18. So there's a way of remembering that. There's two 18s. And the oxygen content, as we've talked about, is 16, which is the same as the mother. So a term baby has an oxygen consumption of about 5 mils per kilo per minute, and you know that they roughly weigh about 3 to 4 kilos, so that's about 15 to 20 mils a minute. And 1,000 mils a minute is about their cardiac output. And as we've said, 25 to 50% of that goes to the placenta. So those are all of the numbers about flow and oxygen content and some of the gradients for oxygen transfer. So then we start talking about some of the specialized functions that occur within the placenta to facilitate that. We've talked about how thick the membrane is, and the detailed ultrastructure of the nature of where the blood is flowing in the cotyledons is not something we would expect from intensive care people in the exam. What we really want you to know is how blue is the baby and how pink is the mother, and then how is that affected by the nature of the circulation in the baby. And next week or next time, we'll talk about the transition and the neonate. But there are a couple of key features of that oxygen transfer function that occurs and the CO2. And one of them is what's called the double Bohr effect, and the other is the double Haldane effect. Now, the Bohr effect is a function of oxygen transfer, and you know yourself, oxygen is much more likely to be transferred when you've got an acidic environment. So you've got a mother that's got an alkalemic blood system pumping into a placenta and passing by blood that's very acidemic on the fetal side. So there's a tremendous tendency for that oxygen to be released. Okay, so that's the Bohr effect. And when the oxygen gets over to the baby side, as that hemoglobin is having its acid status improved as it moves along the placenta, it becomes more alkalotic, and therefore it tends to hold onto the oxygen more efficiently. So that's a reverse Bohr effect on that side. So you've got a Bohr effect moving on one side of the placenta to liberate oxygen, and you've got a Bohr effect on the other side of the placenta working in the opposite direction to suck oxygen even harder. So you've got a double Bohr effect for the baby for oxygen transfer. And the opposite is true with the Haldane effect. As the oxygenated hemoglobin becomes deoxygenated on the maternal side, you've got an augmentation of CO2 binding. And similarly on the baby side, as their hemoglobin goes from being markedly deoxygenated to more oxygenated, and the acid-base changes also occur to function to get CO2 off the fetal circulation and then onto the maternal circulation. So the Haldane effect works in one direction for the baby to liberate CO2, and then work in the opposite direction on the mother to facilitate CO2 binding and dissolution into plasma. So you've got the double Haldane effect. So the double Bohr and the double Haldane effect work to optimize oxygen transfer from the mother to the baby and to optimize CO2 clearance from the fetus into the mother. Okay, it's an amazing system. And one thing you should all do is to draw the oxyhemoglobin curves with the saturation and PaO2 for a normal adult and for a fetus with a P50 of 18 as opposed to 27. And then what you want to do is change that curve and do it with content, because if you convert the saturation to content, you'll see that the maternal curve is quite low and the fetal curve is rotated to the left, but also rotated vertically. And that exemplifies how it is that the oxygen content is the same for a lower saturation in the baby than the mother. So it's very important to remember that the fetus has a much higher concentration of hemoglobin with a lower P50, and that actually sucks the oxygen off the maternal hemoglobin very powerfully because of that increased affinity for oxygen that fetal hemoglobin has. And you remember that the reason that occurs is because fetal hemoglobin doesn't have the beta chains, so it doesn't have 2,3-DPG binding capacity, so it has less capacity to deliver oxygen than the mother, so it has a greater affinity for absorbing oxygen from the placenta.
Thanks, Mike. That's very comprehensive explanation of the uteroplacental circulation and its gas exchange. So we'll be back with another snippet in week's time. So till then, goodbye and have a nice time.
Thanks very much, Swapnil. We'll see you next time. Talk about something I'm a little bit more comfortable with, which is babies and breastfeeding.
That's right. You'll be the best person to describe that one.
My wife would beg to differ.
Okay, see you next time.
Yeah.